Good evening, everyone. Today we will be discussing about approach to neurodevelopmental disorders in children. So during this presentation, we will see what are the neurodevelopmental disorders and what are the general risk factors or etiology of these neurodevelopmental disorders, what are the principles of early detection and management, and we'll have a glimpse of some common neurodevelopmental disorders, how do you evaluate them clinically, and the principles of management. Now, what are neurodevelopmental disorders? They are multifaceted conditions characterized by impairments in cognition, communication, language and speech, behavior, motor skills, memory, learning, and no other neurological function. So you would see that most of these neurodevelopmental disorders occur due to abnormalities in brain development. Because it affects a lot of functioning, it usually results in impairment of personal, social, academic, and occupational function of an individual. The neurodevelopmental disorders manifest early in the developmental period and typically persist across the lifespan. Now, these conditions could co-occur with each other. Some of the examples of neurodevelopmental disorders are autism spectrum disorder, attention deficit hyperactivity disorder, language disorders, learning disabilities, intellectual impairment, and motor disorders like cerebral palsy, developmental coordination disorder, or what we used to call dyspraxia, and also impairments in sensation like vision and hearing, and also quite uncommon ones in Sri Lanka, like alcohol-related neurodevelopmental disorders. Now, before understanding the basis and etiology of neurodevelopmental disorders, it's important to identify the experience-dependent synapse formation in brain. So we all know that brain has architecture forms by forming synapses between neurons. And this neuron synapse formation is based on or dependent on experience a child have from birth to the adulthood. Now, as you can see in this very famous graph of experience-dependent synapse formation, during the initial months of life, the synapse formation happens at very rapid rate, and then it comes to plateau within first few years of life. So, as humans, our brain development has two main components. So there's a genetic component which you carry from the conception, and then the environment helps to shape it. And when some adversity happens to brain, it is again could be due to genetic factors as well as environmental factors. And depending on where it affects on the brain and how much it affects, the different manifestations occur. And that is how we see different neurodevelopmental disorders. Now, epigenetics play a very important role in neurodevelopmental disorders because the environment could act as a switch where certain genetic impressions could manifest in a child. For instance, whether the particular neurodevelopmental disorder manifests or not might depend on epigenetic switch based on the environment the child is in. So what are the genetic and environmental factors that can cause neurodevelopmental disorders? Now, often a positive family history is visible because there's a huge genetic component in most of these neurodevelopmental disorders. And certain genetic syndromes are commonly associated with them. For instance, autism spectrum disorder is commonly associated with tuberous sclerosis, muscular dystrophy, trisomy 21. And advanced parental age is again quite described with the incidence of neurodevelopmental disorders. Things like maternal nutrition, exposure to substances, medical conditions, Male gender is a questionable risk factor because there's a doubt whether the females are underdiagnosed when it comes to neurodevelopmental disorders, and the perinatal complications as well as the adverse childhood experiences are well described risk factors when you discuss neurodevelopmental disorders. Now, how common are they? Well, a systematic review in 2022, so this is very recent article, describes that neurodevelopmental disorders fluctuate very hugely across the globe. And as you could see, the different neurodevelopmental disorders have different percentages. So for instance, you can see autism spectrum disorder, we see about 0.7 to 3% across the globe. And motor disorders is about 0.7 to 17% across the globe. So, how do we identify these neurodevelopmental disorders in a child? So, as I said earlier, they happen in abnormalities in brain development. Therefore, it manifests as atypicalities in child development. So, what is child development then? So, child development is a sequence of changes that occur in a child, where child evolves from infant who's often helpless to an independent adult. So these developmental skills are in different domains. We describe them in different domains. Motor skills, where we talk about gross motor and fine motor, communication and spatial language, social emotional, and the cognitive skills. So based on the developmental milestones and developmental skills, we would be able to identify neurodevelopmental disorder in child. So how do we do that? So this often happens in different ways, and the commonest way the neurodevelopmental disorders are identified is a developmental screening or a developmental surveillance. So that is based on what we call the developmental milestones, and depending on the limit age where certain milestones should be achieved, a developmental screening or a surveillance would help to identify at-risk children for neurodevelopmental disorders. As well, there are well-known red flags described for neurodevelopmental disorders. So identify these red flags in a routine healthcare visit again helps to identify neurodevelopmental disorders. Again, very specific diagnostic assessment, particularly when the screening is positive, helps to confirm the final diagnosis. So, once we diagnose a child with neurodevelopmental disorders, how would we approach that child and family, and what are the principles of management? Now, principles of management we base on this important concept, the International Classification of Functioning, Disability and Health, introduced by the World Health Organization. Now, this describes child not as an individual, and the presentation child has not only as a medical condition, but to look at the child and family as a whole to improve the quality of life. Now, we do not only look at the body structure and function of the child, but we also look at the activity limitation and participation of the child when we are deciding on the management. These outcomes would depend on environmental factors of the child and the family, as well as the personal factors. So modifying these factors are quite important to deliver the final outcome. So the neurodevelopmental disorder management is not a single professional's job. It's often multidisciplinary, interdisciplinary discussions happen often, and there's a multidisciplinary approach. So there are huge team involved with when we are managing a child with neurodevelopmental disorder, and often the interventions are evidence-based, and we encourage early interventions, and often these interventions are happen in family-centered, enriched environment and often based on fixed and agreed goals. So it often happens in a cycle where we identify a deficit and we set goals together with families and we execute through necessary specific interventions, and then we assess the outcomes and the cycle goes on. Okay, so we discussed very basic principles of neurodevelopmental disorders. Now we will go into few very common and important neurodevelopmental disorders. I will discuss them as case studies so you will understand them better. Okay, so case number 1. This is a girl born at 32 weeks of age and had intrauterine growth restriction, neonatal sepsis, and needed mechanical ventilation at birth. And she was followed up at Well Baby Clinic, had delayed motor milestones, but reassured that she was premature. She never had regressions. This is quite common scenario we come across, and the child presents to us around preschool age with delay in motor milestones. So when we come across a child like this who has perinatal insult, so there are prematurity, IUGR, sepsis, needed for mechanical ventilation, with delay in motor milestones, and your observation, you obviously can see certain neurological abnormalities that would help you to finally come to a diagnosis. Okay, so what were the examination findings? So this, they are checking the response to, so you can see clonus as well as what we call a spastic catch. So when you do a velocity dependent muscle stretch, there's a sudden increase in muscle resistance, which you will experience as a spastic catch. Where the muscle will stop in the range of movement. And then now I'm doing a passive stretch. So this will show after the spastic catch, there is a dynamic contraction. And then there is hyperreflexia. So all these things point to an upper motor neuron type of function. And as well, you can see on this video that she is having upward big toe, which is an indication of dystonia. Okay. So what do we have here? A velocity dependent resistant to stress. So there's spasticity, there was dystonia, there was spastic catch, there was clonus, and there was hyperreflexia. So this is a child who has perinatal insult, a delay in motor milestones, and demonstrable upper motor neuron signs. So the diagnosis is cerebral palsy. So what is cerebral palsy? It's a group of disorders, a permanent one, but the clinical picture can be changing. And this is a disorder of movement and of posture and of motor function and of activity limitation. Now, this is due to non-progressive interference in the developing brain. So in this child, we have non-progressive interference, which happened at birth, the prematurity, IUGR, sepsis, and mechanical ventilation. And then we could see a disorder of movement and posture. So there was abnormality in tone, abnormality in power, the reflexes, and then she has limitations in activity and the motor functions. And this motor disorder, this is again part of the definition. Cerebral palsy is often accompanied by sensation, perception, cognition, communication, behavior disturbances, and also epilepsy and secondary musculoskeletal problems. So as trainees, you should be very familiar with this definition. Now, with that, the evaluation continues. So this is not actually the same child, but having a child having a similar gait pattern. So this is what we call diplegic gait, and we are looking at the equinus. So you can see the angle between the foot and the leg, where there are different types of gait patterns we are looking at. So this was only an example of types of diplegic gaits I have referred here, but depending on the presentation, the different gait types are described. Now, again, during my assessment, I demonstrated how the contracture assessment was done. So as you will remember in the video, there was a spastic catch where when the high velocity stretch happens, and that we take as R1. And then from there, we are trying to do a very passive stretch. That passive stretch range is actually your dynamic contracture or dynamic tone, which would be corrected by interventions like Botox. And if you still cannot go beyond what is considered as normal range for that muscle, so imagine that you can dorsiflexion, normal range is here, but your R2, where your passive stretch stops, is here. So this range would be your fixed contracture, which unfortunately will be only addressed by orthopedic interventions. So we try to avoid having fixed contractures in children as much as possible by early interventions. Now we look at the gait, we look at the contractions, then we look at, as you could remember, the definition say activity limitation. So what is the functional level of this child? Now there are different functional classifications for cerebral palsy, and I'm only demonstrating here the gross motor functional classification system. But remember, there are classification systems for manual ability, which is for fine motor, communication function, eating and drinking. So when a child comes with cerebral palsy, we assess all the functional levels. So GMFCS level helps you to identify the level of functional impairment in child with cerebral palsy. So GMFCS 1 and 2 are independent focus, whereas from 3 onwards, you need some sort of help or mobility device for ambulation. And as you remember, there are comorbid conditions. So when a child with cerebral palsy comes, you will be assessing all the comorbidities in that child, including the pain, ability to engage in schoolwork, their development and cognitive level, their communication, whether they need some augmented alternative communication for speech and language, and then whether there are seizures, the seizure management is important, bowel and bladder control, sleep, as well as the comorbid sensory deficit like hearing and vision. And again, dysphagia is quite common in cerebral palsy. So assessing for assessing eating and drinking ability is quite important when you're managing as well. Okay, so we talk in that child, the clinical evaluation when a child presents at that age with clinical signs. But the way forward is to detect cerebral palsy before the child develops, particularly the musculoskeletal complications. So now we are moving towards the very early diagnosis of cerebral palsy based on international guidelines on diagnosis. So we get the help of standardized motor assessment, which is the one used less than 5 months is general movement assessment, and neurological examination we use is Hammersmith for neurological examination. So with combination of these standardized assessments with or without neuroimaging, we would be able to very accurately predict cerebral palsy even less than 5 months. So when the child is more than 5 months, it's often helpful to use certain developmental milestones and red flags. So there are different red flags described to catch cerebral palsy early, like hand preference before 12 months of age, inability to open hands at 4 months of age, if the child weight bears, inability to keep the whole flat of foot on the ground. If the child is tiptoeing, then again there is a indication that child probably has cerebral palsy. If the child is unable to sit independently by 9 months. So likewise, there are risk factors that you need to look at in child's development to detect cerebral palsy early, because about 10% of children with cerebral palsy might not have any perinatal risk factors. So the management, as I said again, are quite evidence-based. So this is the very famous traffic light article where the most evidence-based interventions were summarized for management of cerebral palsy. So the basic principles are, we go for very task-specific training. The environmental enrichment is a must. And for gross motor, it's mostly the mobility training, and we can even go for treadmills. And for hand functions, it's always bimanual and also the could be using constraint-induced manual therapy as well. For the hypertonia management, it could be either generalized oral drugs to lower hypertonia or localized interventions like intramuscular Botox injections. And with casting and orthotics, we are trying to manage the motor aspect of cerebral palsy, as well as I said, the comorbid condition management is quite important. Okay, so that is cerebral palsy. It's quite important. The things like hip surveillance is looked at when you talk about cerebral palsy. So according to the guidelines, we usually use Australian hip surveillance guideline to look at regularly at hips clinically and radiologically to prevent hip dislocation. And as I said, the holistic approach is important. So looking at child's growth, the pain, medical comorbidities, mental health, education, as well as the social aspect is quite important. Okay, so we move on to the second scenario. So this is a 24-month-old boy, and we are looking at child's play skills and interactions. So you can say when the examiner and the mother are trying to play and establish a relationship, there are certain things that is quite atypical in this child. So as you can see, the child rarely looks at the examiner, child rarely shares the interest with the mother, child rarely uses gestures, he does not ask for help. There's quite limited emotional variation, and obviously his eye contact I talked about, and there's some repetitiveness in what he's doing. So here what we talk about is autism spectrum disorder. So autism spectrum disorder, according to the DSM-5 criteria, which is the current criteria we use to diagnose, has two major pillars when it comes to diagnosis. First one is persistent deficits in social communication and social interactions across multiple contexts. So the social communication or social interaction deficits we diagnose by looking at three main aspects. First one, deficits in social emotional reciprocity. So where a child would have abnormal social approach, they might not have back and forth communication, they might not share interests or emotions, they might not initiate interactions with others. And the second thing, we look at deficits in nonverbal communication used for social interaction. So limited use of gestures, limited integration of verbal and nonverbal communications, abnormalities of eye contact and body language, and lack of facial expressions. And the third one is deficits in developing, maintaining, and understanding relationships. So these children find it very difficult to manage or cope in social context, difficult to understand the friendships, relationships, and they probably might not really be interested in peers. The second major criteria is restricted and repetitive patterns of behavior, interest activities. And again, we look at four subtopics under RRBs. So first is stereotypic or repetitive motor movements or use of objects or space. So if the child is having motor stereotypies, it could be hand flapping, jumping around, or the the street side of it. If the child is quite echolalic, repeating the same thing, or using predictive phrases, the learned phrases from cartoons, from programs, in not in a context, so then that is stereotypic and repetitive use. Second sub-criteria we look at insistence on the sameness or inflexible adherence to routines or rituals. So again, the child would be very disturbed if there are new environments the child is exposed to, and then there will be very rigid way of thinking. So it's the children would be quite inflexible when it comes to changes as well as changes in their routine. So they want to follow the same exact pattern in doing things. They might have different rituals. Even eating, they would prefer the same food. Dressing, they would go for the same clothes, likewise. And third subtopic we look at is highly restricted and fixated interests that are abnormal in intensity and focus. So we look at the unusual interest in children where the interest is so intense and so deeply known, but if you check the rest of the knowledge on general understanding of the world, there's a huge disparity between. So a child could be knowing everything about dinosaurs where they might not even know how to count from 1 to 5. So there's a quite disparity about the knowledge in certain areas, and probably the area of interest would be quite unusual, like interest in different type of blocks, the interest in different type of soils. So the very specific, very deep, unusual interest. And the fourth subtopic is actually hyper or hyporeactivity to sensory inputs or unusual interests and sensory aspects in the environment, where the child would be very sensitive or hyposensitive to things like sounds, the tactile sensation, the taste, and also smelling, how the fascination with the lights and movements. So they might keep things very close to their eyes. They might squint their eyes to look at different things, so things like that. And when those two major deficits present in child, the deficits in social communication and interaction and restricted repetitive behaviors, and when those two major criteria affects the social functioning of a child, and if it is present from early developmental period and not explained by other clinical conditions like intellectual impairment, then we diagnose a child with autism spectrum disorder. So autism spectrum disorder typically diagnosed around 2 to 36 months of age. However, even earlier, you could see prodromal period where there are red flags. That child probably had motor differences. There could be feeding difficulties, impaired eye contact, emotional reactivity could be impaired joint attention. And typically, within 2 to 3 years, they come out with social communication difficulties, delay in language development, sensory abnormalities, repetitive use of objects, or unusual play. Now, we talked about red flags of neurodevelopmental disorders. So when it comes to autism spectrum disorder, these are the ones suggested by American Academy of Pediatrics. So if a child is not responding to their name by 12 months of age, if the child does not point to an object of interest by 14 months of age, the child is not showing Pretend play by 18 months of age. So these are the red flags for autism spectrum disorder, as well as there are several other red flags you would look in a child. When we talk about child's development, whether this child could be having autism spectrum disorder. So when we diagnose a child with autism spectrum disorder, according to DSM-5, we often describe that with a level. Level 1 is quite functional and level 3 requires very substantial support. And also there are subtypes we describe autism spectrum disorder. So with or without language impairment, with or without cognitive impairment, without as well. And the diagnostic assessment would not only be on the features of autism, it would be very comprehensive assessment including communication, language, adaptive functions, emotional behavior, as well as co-occurring conditions. So the diagnostic criteria are fulfilled by history as well as observation and sometimes qualitative assessment like ADOS, Autism Diagnostic Observation Schedule. Now, goals of interventions are to minimize the core deficits and the co-occurring associated impairments, maximize functional independence, and minimize problem behavior that interfere with the functional skills. So the early interventions again in autism spectrum are quite important. So the intervention should be started as soon as possible. They should be active and intense interventions. So the task which will be given would be quite developmentally appropriate, again quite goal-based and systematically planned. So we ask parents to integrate them into their lifestyle. So as much as possible, these interventions happen throughout the day and try for the planned teaching opportunities during the day for specific impairments. Now, children with ASD, as we discussed, would have language impairment in addition to the deficits in their communication. So probably they might need very specific speech and language intervention. And some children, due to their level of verbal communication, might need augmentative and alternative communication method where they need a device or a picture book, low-tech AAC to help with their communication. Okay, so that's basically autism spectrum disorder we talk about. Now, the final case scenario. Well, there are two case scenarios here. Now, the first one, this is a term baby who had difficulties in establishing feeding and had documented hypoglycemia during perinatal period. And at 4 months, he was referred with concerns about poor social interactions and poor social smile. As you can see, you may notice now I'm trying to kind of even bring the object closer to see whether the child has any sort of visual attention to the object presented right in front of his eyes, right in front of his visual field. But now in a different environment, child has very good visual attention. He fixes and follows. Now, what is the difference? The difference is now the child is in dark environment. The presented picture is a large in contrasting background, and there is a light focused onto the object or the picture. So you can see difference in the fixing following the visual attention. So what we talk about is cerebral visual impairment or CVI. This is we call phase 1. Now another child. So this was actually again a premature preterm. So born at 30 weeks, needed ventilatory support and
had preview stay for 3 weeks, then followed up in the well-baby clinic up to 1 year, did not notice any abnormalities, and now coming at 5 years with delay in speech, poor attention, noted by preschool teacher. So again, quite common scenario, discharge from the well-baby follow-up and then presenting later with neurodevelopmental disorder. Now you can see how this child looks at pictures. So she's looking at on the way she looks at pictures is from her lower visual field, and when we use the pictures which are in a white background, the small details she still can point out, but still you can see how she's looking at. But when the complex background is presented in a very crowded picture, you can see she's moving quite close. She's not sure what she's pointing to. She's trying to find out the requested objects. So this is cerebral visual impairment phase 3. So this is how the phase 3 would look like. They will have certain degree of vision, but when it comes to complexity, complex visual functions, they have difficulties. Now we describe 10 visual or behaviors when it comes to cerebral visual impairment. So the children, particularly in phase 1, would have color preference. So they might only see certain colors and they need some movement to see whatever is presented to them. And there's a latency. So when an object is presented, the brain will take some time to identify that object in front of your eyes. And as you could see in the second scenario, there's a visual field preference. So the child is looking always towards the lower field. And then difficulties with visual complexity, where it was demonstrated in both scenarios. In the first one, we got rid of a complex background by switching off the lights. The second one, she found it difficult when the picture was quite complex and the contrast was less. Now, these children would have light gazing and non-purposeful gaze. They also have problems in distance. So when you remember in the second case scenario, the child brought her face down to see what's on the book clearly. So trying to reduce the distance. And then there are atypical visual reflexes we talk about in visual CVI, and then they find it difficulty with visual novelty. So they find it difficult to identify novel objects when compared to the objects they are used to. And then there is abnormalities in visual motor function, so absence of visually guided reading. So there could be problems in ventral stream or dorsal stream in the visual processing. Now again, the risk factors are the birth asphyxia and the prenatal hypoglycemia. They are the commonest risk factors when we discuss about CVI, but there are a lot of other risk factors which are associated with CVI. Now, the phases are depending on the what we call CVI range, where we look at different 10 visual behaviors I described, where the CVI phase 1 is the experiment and CVI phase 3 is almost near typical vision, but there are difficulties in certain visual functions. So how do you intervene and manage CVI? Again, early interventions have better outcomes. So in phase 1 child, where they have very poor visual attention. So like in the first case scenario, the interventions are to build visual behaviors. So get the child to look at something. So we will use the given colors, you produce some movement to the object, you give it to very close to a child's face, you give it to the preferred field, and you try to establish brain pathways for vision by stimulating vision in the preferred area. So you try to get the visual attention. When it improves, when the child is in phase 2, what we are trying to do is integrating it with the visual vision with the function. So the functional vision when eating, when writing, when walking around, whether this child needs some adaptations in the environment to have a functional vision. In phase 3, you more look at the complexity. So for instance, there are children who find it difficult to read. So the adaptations like highlighting the text using a high contrast background, larger font size, bold fonts would help child to work better in with a CPI. Okay, so we talked about the overall definition and the etiology of neurodevelopmental disorders and how do you approach generally neurodevelopmental disorders and principles including ICF framework, and then we discuss about cerebral palsy, autism spectrum disorder, and cerebral visual impairment, which are quite common neurodevelopmental disorders you come across. So thank you very much for your time. And if you have any questions, I am happy to answer those. Thank you.